Okay, so as Nick said, my name is Nicole Ammon. I'm the manager of integrated healthcare initiatives in the Department of Psychiatry in the Best Center. Um, and my focus in the Best Center is on integrated primary and mental health care. So today we're going to talk about sexual health, which is just one kind of large facet of integrated care of general health care, so sexual and reproductive health. Sexual health is not something that we tend to talk about in, quote unquote, polite company, but sex and sexual health is a major part of every human life at some point, and good sexual health is a basic human right. The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences that are free of coercion, free of discrimination, and violence. Research indicates that individuals with serious mental illness, such as psychosis, have lower rates of being in longer-term romantic relationships, including but not limited to marriage, and lower rates of sexual activity in the past 3 months when surveyed. And that said, normal sexual development for the people we work with includes all people, including participants of coordinated specialty care for first episode psychosis. And that normal sexual development includes ambiguity, exploration, and changing needs over time. Access to sexual health is really important, and assessing sexual health can give the healthcare team an important information about the patient's health, well-being, and overall health goals. Sexual health concerns or dysfunctions might cue us into undiagnosed health conditions. There's a large meta-analysis that demonstrated a correlation between erectile dysfunction in men, an increased risk of negative cardiovascular outcomes, and all-cause mortality, as well as finding that sexual health concerns can be associated with obesity, diabetes, obstructive sleep apnea, and metabolic syndrome in women. So in addition to that, collecting sexual orientation and gender identity information as part of our sexual health assessment can allow providers to address some of the problems that drive disparities for lesbian, gay, bisexual, transgender populations. And across sexual orientation groups, 22 to 42% of respondents who have reported that they've experienced a persistent sexual health concern in the past year, compared with only 8 to 15% actually talk to their health care provider about it. So this shows a gap between the prevalence of sexual health concerns and the extent to which they actually get addressed. The participants you work with potentially face a number of health disparities in the area of sexual health. People with serious mental illness diagnosis have been found to be an increased risk for engaging in higher risk sexual behaviors, putting them at higher risk for sexually transmitted infections. Women with mental illness have similar pregnancy and parenthood rates to the general population, but are at an increased risk of unplanned pregnancy complications, including miscarriage, worsening mental health symptoms during and after pregnancy, and potential for custody loss following pregnancy. And this is in addition to higher rates of accessing abortions. People with serious mental illness are less likely to access routine reproductive and sexual health care services, including things like protective contraception, recommended preventive screenings and care. For example, numerous studies have shown that women with schizophrenia have lower rates of screening for cervical cancer, although there is some evidence that screening rates improve if the woman is engaged in kind of generally healthcare, as a whole more often. And although causality remains uncertain, there is a recent study that showed that exposure to prolactin elevating antipsychotics for more than 1 year was associated with increased odds of developing breast cancer in women with serious mental illness. So when prescribing antipsychotics, the shared decision making should take this as a potential additional risk factor to consider in the bigger picture. When looking specifically at sexual and reproductive health for young participant groups, so that kind of ages 14 to 24 years, the literature notes that adolescents and young adults in general experience a disproportionate burden of poor sexual and reproductive health outcomes. Sexual vulnerability at this stage is associated with initiation of sexual activity, relatively poor health literacy, and higher risk of being sexually exploited. A systematic scoping review of empirical studies and case reports focused on sexual and reproductive health issues in young people. There's 17 empirical studies and 52 case reports, and most of all of those focused on sexual dysfunction, which was identified as common amongst this cohort, and it was associated with both psychotic disorders and antipsychotic medications. And while some of the sexual dysfunction are attributed to antipsychotic medications, there was a significant portion of young people with psychosis independent of pharmacotherapy that were also expressing some sexual dysfunction. In this scoping review, it also noted there's really a lack of interventional studies on managing sexual risk-taking behaviors or sexually transmitted infection risk in those with early psychosis, a lack of research on women's sexual health topics, including pregnancy and abortion in early psychosis, and very little existing work on gender-based violence, coercion, or issues around sexuality and gender amongst this population. So, and further, very few studies looked at sexual preference or provided the opportunity instead for participants in these studies to self-identify. So, in terms of sexual health for young populations with psychosis, there's really not enough research that is focused on maybe much more older populations. So why do the disparities exist? Well, we know that there's disproportionate rates of sexual assault, domestic violence, and victimization for individuals with serious mental illness. Probably the most talked about reason for some of the disparities and some of the sexual dysfunction is the side effect of medications. So this is at least one thing that our prescribing nurse providers might more commonly ask about. But medications cause more than just sexual side effects. They can actually impact reproductive health. Examples in the literature include infertility, which persons with serious mental illness statistically experience at higher rates than the general public already. Detrimental impact on fetus if a participant is taking medication during pregnancy. And please don't ask me to elaborate. That is not my field. My background is counseling. But I'm sure there's a physician, nurse practitioner, or pharmacist that could much more easily explain those linkages. Other possible causes of disparities are comorbid health and lifestyle factors, things like smoking, substance use, obesity, your other standard social determinants of health. Health literacy can impact sexual and reproductive health, and participants might have an even poor perception or awareness of the overall risk that they're at. And interestingly, when it comes to engagement in higher risk sexual behaviors, there is a correlation with poorly rated quality of life and more fatalistic views of the future. So when we have somebody that's rating quality of life pretty poorly, this could be an indication that we should be talking to them about high risk sexual behaviors. And this is kind of under the presumption that we're probably not talking about sexual and reproductive health very much with our participants. That is pretty common across most of the literature. So, why is it that we're not talking with people about this more? There's a variety of barriers to discussing sexual and reproductive health across all of healthcare, so kind of primary care, emergency care, mental health care. But since we're focusing more specifically on mental health care, there is a lack of clinician knowledge and training, but that's both on the sexual reproductive health side and mental health sides of care. When people are maybe willing to talk about that, there tends to be a lack of solutions, even if that provider is willing to listen. For participants themselves and for the providers, there's a lack of early education about sexual and reproductive health in general. And that lack of education can be heightened if we're working with immigrant and refugee populations. So there are very different cultural considerations that we need to consider when working with different populations on what is the general sexual and reproductive health literacy for that culture. What is the standard for communication around those topics within those families? It can be quite different. Another barrier to discussing sexual and reproductive health is often the symptoms of psychosis could overshadow other health needs. Sometimes because of the symptoms themselves, maybe some paranoia, some fears about talking about that is directly related to symptoms. Sometimes because of fear of diagnostic overshadowing or actual diagnostic overshadowing. It's very common for clinicians to attribute the symptom of some other health condition to the mental health diagnosis. And there's also issues of stigma and just fears of stigma. Something to consider is that people turn to social media and informal supports a lot. And, parents are not your go-to supports for sexual and reproductive health topics around most young service users. Financial barriers to care. If we know that we don't have good resources and help referral sources to get people in, we often think, well, I can't do anything about it, so why start asking? And in general, sexual and reproductive health topics are still taboo for many, with considerations to culture, religion, age, and gender gaps between provider and patient, and the kinds of settings that you're working in. So who should be asking? And who should be asking kind of depends on who you ask. So in mental health settings, it kind of depended. But there are gender considerations. Female participants have a preference for talking with a female provider about sexual and reproductive health issues. And when there is not a match between, if a female participant is not talking with a female provider, if they have more male providers to talk to, they might be less likely to talk about this. Also, in talking in peer support programs, if there are gender ratio imbalances, that could be an obstacle to some dialogue. When interviewing participants, some think that it's better to talk with a therapist about sexual and reproductive health concerns, but others thought maybe a psychiatrist or nurse. Most participants in some of the studies that I were looking at said that they would be comfortable talking with their mental health provider about sexual and reproductive health issues, but others said that it could be kind of uncomfortable, or maybe they were a little bit ambivalent. There's a question amongst providers' minds on, is this with their place to be talking about it with? Do they have the scope of practice? And they might have had past negative experiences talking with mental health providers in this area. In emergency and primary care settings, anybody really could be asking, but clinicians tend to assume that the participants are going to bring it up if they want to talk about something, or that they're afraid to bring it up because they don't want to offend anybody. So providers are concerned about offending patients and cite beliefs that the patients will bring up the concerns themselves. The flip side of that is that patients often report expecting that the providers are going to bring it up, and they would be comfortable with that, if it was brought up by their provider. In a recent study that included a sample of 429 emergency department providers, about 80% of the providers worried about asking patients about sexual reproductive health, sexual preferences, gender identification, thinking that questions of gender identification could offend them, but only 9 to 11% of participants thought they might be offended. Similarly, in a study of primary care patients from 4 community settings, 90% of the patients think their sexuality and sexual health information is important for the provider to know, and only 10% thought that they might not be willing to answer the questions. Pregnancy and contraceptive issues can be sensitive topics, particularly for low-income women and women of color, as their reproductive rights have not always been honored in medical settings, and that's something that we need to be aware of. I mean, it was as recently as the 1970s that women with mental illness were subjected to involuntary sterilization. And these groups do have higher rates of domestic violence and sexual trauma. On the kind of system integration side, and this is something that I think is particularly valuable to talk about within this setting, is that we tend to want more system integration as clinicians. We think that that's convenient. It does make it easier for all of us to be on the same page and to make sure that everybody's needs are being met. But some of the service users researched in some of these studies or were interviewed in some of these studies actually liked the systems being a little bit more siloed between sexual health providers and mental health providers. Kind of liked that anonymity and not having to talk about their sexual health in all settings. So it's really going to depend on the people that you're working with. But from my point of view, and I think the point of view of many clinicians, who are trying to work on more of an integrated style to care, we should start talking about it or opening the space to talk about it with participants. So how do we start doing that? It really starts with assessing your own comfort and biases. Religion, society, culture all influence our views and attitudes about sex and sexuality. And we need to be comfortable about it if we're going to actually engage in a conversation or give our participants space to feel safe doing that. So we want to create a comfortable environment, establishing rapport and creating an environment that is trauma informed, recognizing that many individuals have experienced trauma and we may or may not know about their trauma, but trauma has many personal and societal consequences, and we want to anticipate how people might respond to our words and actions. So creating a space where we can avoid doing any further harm. We also need to create an environment that's sex positive. Sex positive just means an attitude about sex, gender, sexuality that's free of judgment and supportive of open expression. It doesn't mean that we're encouraging or discouraging sexual activity. It just is, having a positive, supportive environment for the expression of sex and sexuality, and gender and sexuality. Sex positivity is really about re-educating ourselves and being open to diverse points of view. The timing of these conversations can matter, and there's varying opinions about whether you should be discussing this early at intake or after building rapport. And I'm sure we can make an argument for both sides. I could have my arm twisted. I think depending on the timing, really, I think there's an argument on any space that you can do it. But the optimal timing really depends on rapport and competing priorities. If it's brought up early, it could be setting the foundation that this is a topic that's always okay to talk about. And it could be used in means of like universal screening. So we're going to ask everybody certain questions just so that we have this sexual health information. But bringing it up later allows for more comfort and relationship to be developed. Sexual and reproductive health goals might feel like a sensitive topic. Service users might not want to discuss them with mental health providers, certainly at first, so you want to ask permission. And you might need to help people understand the purpose of asking the sexual and reproductive health questions. So things like, I'm asking this because it will help us think about your medications. It might help me to gain an understanding of your goals and what resources I could provide. Or simply, I just want you to know that this is an open topic. Making sure to keep a trauma-informed lens is paramount, though. Adverse childhood experiences or adult experience of sexual abuse or trauma could affect a person's ability to discuss these topics comfortably. So there are strategies for taking a sex-positive health history. So that would include, gathering basic information, and that sex-positive health history is found in the philosophy that consensual expressions of sexuality are healthy, and it intends to strip away the belief that some types of sex are more acceptable than others. So being sex-positive affirms a person's right to enjoy the kind of sex they're having without feeling judged. It requires comprehensive education, particularly in sexual practices, pregnancy, family building, and sexually transmitted infections. So start gathering things like preferred name, preferred pronouns, orientation, and gender identity, making sure to include using inclusive neutral terms and a common understanding of terms. Transition into asking sensitive questions, asking if it's okay, ask for permission before getting into some of the sensitive questions. Asking people if they have any concerns about their sexual health in general, and making sure to avoid to pose your questions in a non-judgmental manner. So avoid assumptions based on the participant's age, appearance, or marital status. Avoiding assumptions about their gender identity, their sexual orientation, or sexual practices. And being willing to rephrase your questions if a patient seems unsure how to answer or reluctant to answer, potentially offended. And try not to react overtly if you feel uncomfortable. So paying attention to your own body posture, your own body language. The CDC recommends a 5P approach, so asking about partners, so current partners, past partners, gender of said partners, practices, so the acts themselves, and this might be maybe more for the physician-nurse team, but it's important to understand that some aspects, the practices that a person engages in, helps us to assess their general risk and their risk behaviors. So things that might feel more applicable for a therapist to ask about is like, how do you meet your partners? Do you meet them online? Do you meet them through apps? Have they ever exchanged sex for, insert blank need? Where are they having sex? How soon after meeting a partner are they having sex? Are they using protection? How do they stay safe, both in the sexual activity and in kind of the dating activity or the meeting new people activity, reinforcing positive safe sex practices, particularly if they're engaged in higher risk practices. Past history, so that have they been tested for STIs, HIV, would they like to be tested? Do they know if their partners have been tested? history of any kind of sexual trauma. And then pregnancy intention. So things like, do you think you would like to have children or more children if they already have some at some point? When do you think that might be? And how important it is to you to prevent pregnancy until then? What kinds of birth control or contraception are they using? Do they need any additional information about it? A more recent approach in one of the studies that I read for kind of an update on this particular topic, they added pleasure to the CDC's 5P approach, so taking a 6P approach. So including questions like, how satisfied are you with you or your partner's sexual functioning? Has there been any change in you or your partner's sexual desire or frequency of sexual activity? Do you or your partner use any devices or substances to enhance your pleasure in the sexual activity? And using basic motivational interviewing skills can help navigate these conversations, and taking a harm reduction approach. So that harm reduction being the means of preventing disease and promoting health behaviors that meet people where they're at instead of making judgments about where we think they should be at. And getting comfortable is really that biggest first step. So there was a quote in one of the studies that I read that said, if you aren't comfortable taking a sexual history from your grandmother, then you're not ready to take a sexual history from anybody. I don't know how I fully agree with that, but it's worth a try. So this is just a pocket card style of all of those questions that I went over in the previous 2 slides. I included it in case that's relevant and useful to you or your practice so that you can kind of see it spelled out there. So despite all the challenges and disparities and what have you, being in an intimate relationship, becoming a parent, our general sexual and reproductive health is a strong motivator for people being in recovery. Study participants note that having a socially valued role like being a parent can provide a buffer, or being in a committed relationship can provide a buffer for some detrimental effects of self-stigma. As providers, we can do things to help support participants' sexual and reproductive health. So things like normalizing worries, having open conversations, fostering hope, providing accessible information and education about sexual health and pregnancy to help people make more empowered decisions, supporting the development of coping skills, social skills training, offering parenting classes if that's applicable, and peer-delivered interventions, particularly if you have that kind of gender ratio at a good spot. And as always, when appropriate, we want to engage families and those loved ones and chosen families of the people that we're working with. And April is Sexual Assault Awareness Month. People with serious mental illness experience elevated rates of sexual assault and exposure to intimate partner violence, and women and young people with mental illness have unique demands in terms of sexuality and sexual health education, that they could also be more vulnerable to sexual abuse and exploitation. So this is important for us to remember. And as a result, this can create unequal power balances in relationships later in their life, and increased rates of re-victimization in adulthood. There's a 2019 article noted that some research conducted in the UK found that 40% of female patients with serious mental illness in contact with secondary mental health service had experienced rape or an attempted rape as an adult, and 10% of them had experienced sexual violence in the previous 12 months alone. Those who had experienced rape or attempted rape reported having attempted suicide. More than half of those individuals had attempted suicide related to those experiences. In a 2024 systematic review that looked at data between 1989 and 2020 from a range of countries, the studies consistently showed a high prevalence in the past year and adult lifetime sexual violence victimization in psychiatric service users, and even higher rates in the women of those, so women psychiatric service users compared to men. But both male and female folks were found to have an increased risk of experiencing sexual violence compared to those who do not access psychiatric services. So very important for us to be aware of, as this could be impacting a great number of the individuals you work with. Here are some resources. The top resource could be great as a resource to point the participants you work with to. There's a lot of kind of wide variety of kind of resources and educational materials there. It's very family friendly and can give a wide variety of information. So it's a fantastic resource to point to. For ourselves, for kind of more continuing education, there's a comprehensive sexuality education through the World Health Organization. There's also some international guidance through Sexuality Information and Education Council of the United States, so that gives a sense of, or they give some recommendations on what kind of sexuality and sexual reproductive health education people should be accessing. And then for kind of continuing professional development, there is the American Association of Sexuality Educators, Counselors, and Therapists, and they do have a whole section on continuing education offerings through their website, if that's of interest. And then a whole slew of references, just trying to stay on top of this. The last two that I'll include, so one was about the working with refugee and immigrant populations, if you're interested in digging farther into that. And then there was a really neat Health Leads webinar recently around integrating doulas into team care. So for those of you that have patients that are pregnant or want to be pregnant, or are planning, they or their partner are planning to get pregnant, it could be a neat thing to look into in terms of options. It was focused on New York. I don't know how much doulas are used in Ohio, but it certainly seems like a good resource if we can get people connected.